Hello, everyone, and a very warm welcome to today's digital health event organized by PATH and the Infectious Disease Alliance. We are really glad to have you with us for this important session on harnessing digital health for resilient health systems in the changing world. As you all know, health systems around the world are facing growing challenges, from pandemics and climate change to workforce shortages and funding cuts. In the ever-changing environment, digital health tools offer powerful ways to keep services going, improve access, and strengthen how health systems respond to crisis and change. Today, we are excited to hear from a group of experts who are working at the forefront of digital health across policy, partnerships, implementation, and innovation. They will share their experiences and insights on how digital health is helping to build stronger, more resilient systems in real-world settings. We are also happy to welcome Maya Riviera Hildebrand from PATH, who will be our moderator today and help guide us through the session. Thanks again for joining. We are looking forward to a thoughtful and energizing conversation on the role of digital health in shaping the future of global health systems. Over to you, Maya.
Hi, wonderful to see everyone and welcome to this exciting webinar. Really exciting subject on digital health and the intersection of infectious disease, combining two of the biggest buzzwords that we're hearing kind of in the space right now. I'm really excited to introduce our panel and really excited for the speeches and talks that are coming. We have a very interesting discussion at the end of our talks and I think we should just go ahead and get started. So our agenda today are our opening remarks, which we've just heard from Rodrigo. Thank you. Our first speaker is David Novillo-Ortiz, and then we will be hearing from Nima Diop, Magda, Rosin Moller, Abdulhamid Yahaya, and we'll have room for discussion and closing remarks at the end. David, I'm going to have you go ahead and introduce yourself, and then we can go ahead and get started with your wonderful presentation.
Thank you so much, Maya. Thank you so much for this invitation. So the idea for this, well, my name is David Novillo. I am the head for data and digital health for the World Health Organization in the regional office for Europe. I'm extremely grateful for this opportunity, which I'm going to present very briefly what are the things that we consider that we are doing okay in the WHO European region that is composed of 53 countries, and then some challenges that we are facing based on the available data that we have. And the idea of this first slide is basically to give an overview of how we are doing in regards to policy, also about electronic health records, and then also about telehealth in particular. So the next slide, please. Thank you so much. So, so as I have really mentioned, the WHO European region is composed of 53 member states. And we conducted a survey 2 years ago about the status of digital health in our region. And we were extremely grateful that all the countries responded to this question, to this survey, sorry. So we, based on the findings that we have, we always like to highlight 3 in particular. One is related to national digital health policy strategies, and we found out that 44 out of the 53 countries, 83%, have a national digital health policy or strategy. To be honest, that doesn't mean that these strategies have been implemented at the moment. So this is just a quantitative indicator about that they have it yes or no, right? Then we were also asking them about the penetration of electronic health records, and that's just only the graph that is highlighted in this slide, where we can see that Northern Europe is the more decentralized, based connected system. Then we have Southern Europe that reports exclusively national electronic health records. And then we have Central and Western Asia reporting the most significant number of values. So we can see that there is a good penetration when it's about national electronic health records, that overall we can see that the global level is also happening. With that being said, it's true that we have found when we are conducting assessments across the European region, some systems that are still unfortunately paper-based, so that is also a reality. And finally, an interesting positive finding is about the policies related to telehealth. So we can also see that the number is now 78%, 40 out of 51 countries having these policies or strategies. And we need to highlight that this number increased also after the COVID-19 pandemic. So also we saw a direct impact in how the pandemic impacted in digitalization of systems. In the next slide, we are going to focus more in not this positive news about what could be improving in the European region. Next slide, please. Thank you so much, Alice. So first of all, I think that the most interesting negative finding is that only a half of our region has a policy or strategy about digital health literacy. And that is very important because we are massively doing investments in digital health, but then we are leaving behind our health workforce and the population. So for us, it's critical. And actually, when we launched this report, that is publicly available, our main message to the member states was we need to expedite the progress when it's about digital health literacy. Also, an interesting finding is that only 19%, 7 out of 39 countries, have developed guidance for evaluating digital health interventions. So again, we are massively investing in digitalization, but we are dramatically failing in how this is evaluated. So that is also a call to action for our member states. And finally, in the age of AI, we were asking about if countries are developing strategies or policies around big data and advanced analytics, and we found out that only 35% of member states have a policy or a strategy in this area work. The graph is related about what is the most used solution that is been when it's about related to advanced analytics, and of course, artificial intelligence was the most recurrent and cited tool that it has been currently implemented in the WHO European region. So these are basically the two relevant findings that we have when it's about digitalization, just to mention, and to which I heads up that we have just conducted a similar survey, but focusing only on artificial intelligence that will be published in December this year. So just for you to know that a report about the status of AI in the WHO European region will be published later this year. Then in the next slide, moving to the coming work, we have a 5-year work plan. So the next work plan is starting now, and there is a clear wish to include and continue including data and digitalization in the next program of work of WHO Europe. And we can see 4 specific topics. One is empowering individuals. And then basically, this is related to the digital health literacy point that I was mentioned. So we'll need to improve how the health workforce and the population is involved in the development of digital solutions, particularly in the implementation, right? And so that most of you remember when electronic health records started to be implemented, usually the health workforce was not too involved in the development of this. So they were basically told, you need now to work on this with this solution. So now we can see that the same is going to happen with AI, and we are trying to fight that as much as we can. Then, of course, looking at enhancing efficiency, equity, and digital innovation, in which we can see that there are important digital inequalities that we are trying to solve in our region. We can see that any inequality that you can see in health overall is practically replicated when it's about digital health. So that is something that we really need to tackle as soon as possible. Of course, unlocking the potential of AI in health, we can see how all countries are massively investing in AI solutions. So we are trying to support our member states, along, of course, with our colleagues in headquarters in WHO, to really develop proper support so they can really move safely in this important area work. And then an area that is not directly related to our portfolio, but is in the portfolio of another colleague in WHO, that is related to biotechnology and genomics. So that is also that countries are also investing, also by the influence of the European Union. So we are trying to support also in this area of work. And this is basically what I would like to share. I think that I have taken less than 10 minutes, but the idea is just to give an overview about what is happening in the WHO European region and the challenges that we have ahead of us that are, I would say, basically replicated in every WHO region. I think that not all regions have this data available, but we can say that talking to our peers in other regions or partners, we can see that these challenges are recurrent in every single country in the world. So yeah, so with this, I would like to conclude, and thank you so much again for the opportunity.
Thank you so much, David. And I do know that you have to leave a little bit early today. So I just wanted to take the chance. There's some questions that we have for you on, you've already kind of highlighted some of this, but if there's anything, big takeaways you want our audience to hear about how digital health is reaching marginalized populations in low resource settings. If there's any, big points you want to make sure come across, please continue.
Yeah, thank you so much, Maya. So we conducted a review in December 2022 about equity within digital health in the WHO European region. And then we were trying to measure what is available in terms of access, use, and engagement, right? So when we were looking at the access of digital solutions and looking at inequality, we observed that in white and English-speaking individuals and those with no disability, they had better access to digital solutions. We found unclear evidence for social economic status and social capital. And then we also found unclear evidence for the place of residence. So there was, when you look at these patterns, we can see that when it's about access, white and English-speaking individuals were the best access to this solution. And again, I am talking about the available evidence in the literature, right? I think that all of us have a clear understanding of what we can see without producing this evidence, right? So the findings that I'm referring now are basically based on the available literature. So please take this with caution. Then more associations were observed in the use domain when we're analyzing the use. So indication of higher use in urban residents, white and English-speaking populations again, those with higher education, and those with a higher economic status and younger individuals. However, we didn't see clear evidence for when we were related to occupation, gender, sex, social capital, disability, or lack of home, right? That was more related about use. And then when it's about engagement, we really didn't find proper evidence and findings that really help us to understand what are the inequalities when it's about engagement, right? But this is something that we're really very committed. And then as a result of this scoping review that we conducted, now we are moving with some practical recommendations. Some of them are being executed for us at the moment. So one is developing a framework to monitor and report inequalities. We have the first draft almost ready, and the idea is to support countries in how to measure inequalities in digital health, right? Because they're all the time asking us, okay, how we can measure this. So we are close to have a proper framework that will help us to this. Then the second recommendation is to map inequalities in digital infrastructure. And for this, there are available tools. I remember back in the days when I was working for WHO, but in the America region, we conducted the first tool to measure ICT in the health sector. And this tool is from 2014. And then recently in 2022, we have developed other tools that will help countries to measure digital infrastructure, something that is very needed, right? And it will be relatively easy to do. And finally, the most important, and this is more the will of the member states, is to use an inclusive and participatory design when developing these tools, right? That I am referring also this to digital health literacy. It's extremely important that we keep the population and the health workforce involved when developing this kind of solutions.
Thank you so much. It looks like Magda has her hand raised. Magda, do you have a question for David?
Yes, David, fantastic. Thanks for this very concise but very interesting, informative presentation. WHO Europe has done a lot of efforts in bringing and rising capacities across the region. So my question would be, what you plan, you do support the regions, but what are your plans in terms of exchanging good experiences across the region? Some countries are more advanced than others, and I know that you have done this a lot, so I'd love to learn just a little bit about what are the next plans that you will be doing from WHO Europe.
Thank you so much, Magda. So when it's about the WHO European region, to facilitate the knowledge exchange between our countries, we have formal networks that are helping to this knowledge exchange, right? We have particularly one that is a health information network with a subgroup on digitalization and innovation that is actually facilitating this knowledge exchange. And then when it's about going beyond this, we have our colleagues in headquarters that are doing similar efforts to ensure that we can exchange this knowledge. Then, when we are talking about the private sector, for example, that is something that we cannot be neglected, right? Because at the end, I have always said that one of the main problems that we have in digital health overall is that the public needs and the private interests are usually not aligned, right? So for that, in our case, we have an initiative that is called a Strategic Partner Initiative on Data and Digital Health, that is basically bringing member states, private sector, academia, and non-revisional actors that are really trying to work together to align these public needs with private interests. So that are the main initiatives that we are conducting at the moment to bridge this gap when it's about knowledge exchange.
Very good. Thank you.
Thank you so much, David. Really appreciate this, and hope to hear more from you shortly. But good luck with the rest of your day, and thank you again for joining us. If there are any follow-up questions, we'll be sure to send them your way. And yeah, continue to working more with you and hearing more in the space. Great work.
Thank you so much. It has been a pleasure. Thank you.
We're actually going to open up the floor to Nima. Nima, would you like to introduce yourself?
Thank you, Maya. Hi, everyone. Nice to see you. Lovely to be here with everyone today. Thank you so much for joining this session. My name is Nima Jope, and I'm the Senior Partnerships Officer supporting the PATH Central Africa Hub based in Kinshasa. And I'm really looking forward to sharing a bit of our experiences in the beautiful Democratic Republic of the Congo. So much to say about the Democratic Republic of the Congo, a big country and difficult to do in 10 minutes. So I will do my best today, but really honored to be here to talk about digital health in action, insights from our work in the DRC. Being from Senegal originally, I'm always fascinated by the size and breadth of this nation. And one of the things that we note in the Democratic Republic of the Congo is, first of all, its health burden. So it is a country that unfortunately does suffer from high maternal and child mortality rates, recurring epidemics, a bit of the epicenter when it comes to Ebola, Mpox, cholera, measles, malaria, and others. But also in terms of its digital infrastructure landscape, low internet penetration. There is definitely growing mobile coverage, but definitely the country continues to experience complex last mile delivery, which for those of us in the public health sector can note that these are some challenges that we have to always bring about innovative solutions to kind of get around, to reach the beneficiaries where they are. And in terms of its population, I always joke around how hilarious it is when my Congolese brothers and sisters react to the population of Senegal, which is the size of Kinshasa. So the country is of approximately 100 million people, and of its geography, 26 provinces and its vast terrain. And the reason why we wanted to preface with that, if we go to slide 3, is that we really strongly believe, as many here, about transforming healthcare and being able to really accelerate impacts through digital solutions, particularly in supporting the DRC in the pivotal moment in which it finds itself in its healthcare journey, which is through being able to really put in place this vision of the ministry and the president himself in enacting and achieving universal health coverage in the country by 2030. And although the nation is embracing digital health as a transformative force to overcome geographical barriers, it was important to put in place a certain steps of foundational pieces to really ensure that we were able to address infrastructure limitations, workforce challenges as well. And I'll share today with you a little bit about our journey in working closely with the National Agency for Clinical Engineering and Digital Health, the Ministry of Health, the president, and all their stakeholders and partners, such as yourselves, in orchestrating this ongoing digital revolution in healthcare in the DRC. Slide, please. Taking a look at the history, let's take a look back. So in 2009, we established our operations in the DRC, spanning 5 provinces out of the 26. So many provinces to cover. But as of 2008, we were able to support the formation of ANI-CNS, which later became ANI-CNS, as a central coordinating body to serve as really the agency for digital health initiatives within the country. And in 2020, following that, we were able to launch the first ever national digital health strategy in the DRC from 2020 to 2024 with PATH's technical support. And it was important ahead of any transformation to make sure that there was a national strategy in place with clear priorities and objectives so that all actors and stakeholders, including PATH, would be able to align with that and really accompany the country on its journey for digital health transformation. And we are looking forward into the future towards supporting the UHC department and being able to achieve UHC coverage, but through digital health as part of its strategic objective number 4, which is in that plan. Slide, please. In strengthening the Digital Health Authority, it was 4-pronged. First of all, we needed the national governance. Then it was the strategic planning. Then many years and times of capacity building, so technical trainings on digital government, system standards, global goods, and of course, interoperability. Interoperability is so key in the Congo, where we have 26 provinces, some of them the size of an entire country. So in order to be able to make sure that all of the systems can speak to each other and be able to really aid the national coordination level at different areas of the health system in making database decision making, we needed to ensure that those trainings and capacity building was essentially done and engaged in that. But then, of course, the coordination with the existence of ANI-CNS serving as that central hub and making sure that within the country we're aligning digital health initiatives. What you find in the Congo is that all of the stakeholders are using different tools, different systems, different formats, different ways of sharing the information, from paper to e-wires to DHIs to so it can definitely serve as quite a challenge when it comes to reaching high-scale health impact across the 26 provinces when we're working with systems that just aren't able to speak to each other. So that interoperability for us in the Congo particularly is very important and key. Slide, please. And that brought us to what we love the most in sharing. And hopefully with those of you who are interested on the call, we'll have time to dig into the details of this. It's so much to share, but what we call is the digital health enterprise architecture. And if I were to show you the picture of what that architecture looked like, you'd see just the level of complexity that is in it in terms of really being able to map out all of the foundational pieces from the governance framework to the digital infrastructure that needs to be put in place at the different levels of the health system for that architecture to work and move the way it can be. But then the system integration, as I described earlier, about interoperability and ensuring that those frameworks are there so that data exchange can happen properly. But then, of course, the utilization. The data and the quality of the use of the data is only as good as how and where and by what tools in which we're able to collect that data, and making sure that we are making decision making and managing resources as well, basis off of information that is evidence-based. Slide, please. But then community health, empowering the frontline workers. The digitalization of community health services is a critical frontier within DRC's UHC journey, in overall digital transformation. We've supported not only the development of the National Community Health Strategy Program, but being able to pull in the tools and processes and frameworks and also learnings from across the region and best practices as what it really means. And when we talk about equipping, training community health workers who are really on the front lines and being able to bring immense impact in their day-to-day work, what are the tools and what are the ways in which we can really allow them in low resource settings to be able to do the work that is so important for the communities in which they serve. Slide, please. And coming back to UHC, really at the heart of all of this is what needs to be put in place for UHC to even become a reality: digital solutions, digital frameworks, and a digital architecture. Why? Because it is through digital tools that we can enable the health workers to expand coverage, being able to reach previously underserved populations across the 26 provinces in the DRC to the last mile through coordination and through improved geographical coverage and interventions that are tailored to the immense diversity that exists within the provinces in the Congo. And then enhanced quality, being able to support clinical decision-making at any moment in time, standardized protocols, performance monitoring, financial protections, and then data-driven decision-making. For us, real-time dashboards and the introduction of real-time dashboards and analytics to empower health leaders at the national coordination level and provincial levels to allocate resources, but also respond quickly to emerging health needs, which is really, really the pinnacle of anything pertaining to epidemic preparedness and response, is really about the swiftness at which decisions and action can be taken. Slide, please. And as it pertains to health emergency response, we have to have early detection. We have to have rapid verification, coordinated response, and continuous monitoring. And through the data visualization work that PATH has been able to work hand in hand with the NIPH and its subsidiaries, has been able to really aid from the PNLP, which is the NMCP or National Malaria Control Program, to also the CUSPA, which is the coordination unit mandated to respond quickly and swiftly to epidemic challenges as they occur, from Mpox to, God forbid, Ebola or any other really outbreak. These work that we've done at that level, we believe, has been able to vastly shift the dynamics and the ability for the country to really have a better bird's eye view and make the decisions at the right time. Slide, please. So just to sum up here, digital impacts across the DRC. As of today, after having the blueprint of the digital health architecture available and its roadmap and costed out roadmap available for the country and stakeholders, there's to a certain extent some work that has been done. So, for example, electronic medical records implementation, you see here, the number of provinces is supported. And we have also the layout of digital health, community health worker digital tools, LMIS deployment, and DHIS2 reporting. And last but not least, what are our keys to success? If we had to share keys to success, we would first and foremost start with governance. Governance is the main thing. The buy-in at the ministerial country level is the main thing. One of the lessons learned and our best experiences, and of many plethora of examples we have to share here today with you, is the fact that this is co-designed with a human-centered approach, which is really the bread and butter of PATH and to the core of our beliefs, and being able to design hand in hand with the users and the owners of these systems, and having that strong governance, which is why we began with the instilling the NECNS agency, which today is able to play a very critical role in all the governance around digital health and bringing all those actors together, and with that systems approach. But then, of course, local capacity, building that capacity from the bottom up and the top down at all sides. And then, of course, sustainable funding. So being able to really identify innovative ways for domestic investment and coordinated donor support at the ministerial level as well. And then I'll just end here with this last slide here, the way forward. Collaborative action for digital health. We want to continue with coordinated partnership to be able to really be the pinnacle to set us up for successful innovation to scale, and also sustainable integration. Sowing the seeds one seed at a time and seeing those plants being able to grow has been a great experience and journey for PATH, and look forward to any of your questions and hope that we will be able to bring you also on our journey for digital transformation in the Democratic Republic of the Congo. Thank you for your attention.
Thank you so much, Nima. And I do want to highlight that there will be room for questions following the next two presentations. David was just we had to get some questions in there before he had to leave the room. Our next presenter, I believe, is Magda. Iris, do you mind sharing your screen? We can do a quick introduction from Magda and then jump right in.
I think Rolando has raised his hand. So.
Oh, Rolando.
It's a very quick question just to Nima regarding her recent experience with the epidemics, because as we know, the sector has been hard hit by cuts, and I was wondering if you could comment on how having digital data and access to evidence-based information helped you communicate with the donors during these very difficult times of competing priorities.
Yeah, thank you so much, Rolando. Maybe I'll just take that question real quickly here. I think it's really been very, very important. After the shift and major shifts in the landscape that we've seen through the pause in U.S. government funding, it has definitely reverberated through the epidemic preparedness and response efforts. We have seen key activities come to a halt overnight as it pertains to Mpox, particularly. And that has been a cause for concern, of course, because we know that epidemics know no borders. And we've seen that spread through the region from the DRC. But in discussions with the donors, such as World Bank and their investment in the pandemic fund, and other donors such as the foundation and those that we're engaging with, the fact that we invested into data visualization in these data and having that level of information at that level has been very helpful in identifying where the most priority gaps are right now today and where to kind of plug that in. And that has been really helpful us in those high level discussions we've been having. But thank you, Rolando, for that question, and happy to take more at the end. Over.
Thank you. All right. Magda, over to you. I think we can get a bio picked up for you. And then the floor is yours.
Yeah, thank you. And I don't bring slides. I just bring some ideas I would like to share with you. I could have put them in a slide, but I think it will work like this. So I think it's very good that we had that I follow up on a presentation from an international organization that helps coordinate learning and implementation across. And then, Jima, thanks for having this precise look at the one country and see what is challenging. Maybe we can take off my slide and maybe just do you might even want to pin so that anyway. Let me share with you a meeting I had during the World Health Summit in Berlin. WHO Geneva was organizing a session on commercial determinants of health. It was all about how bad the sector is and which we all know all the downside. And I raised my head and said well, maybe there's also some positive about involving business schools or involving those that know about business and following up on probably not only my comment, but in general, they did organize a meeting with business schools exactly on that. What is the role of business schools and how can we help? And I think particularly in digital innovation, particularly the relation for digital innovation and an important role of digital technology in what is infectious diseases and prevention and surveillance, etc., is really important. We have been doing some work with the African CDC in Ethiopia, where we had been looking into how can this actually help digital transformation how can they help digital transformation in others. So I think our role as business school is being this catalyst for digital innovation. We can be kind of filling the gap between the innovators and the implementers, and particularly be this link. It was mentioned earlier, the private sector that was mentioned. Also, we as a neutral partner can actually link to private sector and bring them in, prepare a basis. And here our role is actually to work, and that would be with the Congo, or we have been working in other countries, be it Kenya. I mentioned Ethiopia. I just come back from Burkina Faso, where we actually do work with local educational institutions, business schools, to see how can we support and develop local leaders. And I think this is the important part, that we enhance the role of local actors, be it from the Ministry of Health, be it from the hospitals, be it the professionals, be it the infectious disease specialists, and see with them how they can acquire or develop further capacities in what is the technical capacities of managing digital technologies, but also how to lead this effort and how to build local ecosystems. And I think that's the important role that we can do. And Rolando, I referred to your question earlier. This, I think, is particularly important now that we have the cruel reality of the withdrawal of USAID. I think it's even more important so that we develop or strengthen local capacities of really that there's an ownership taken on solving problems. And here with those that we have been speaking and seeing, we had some discussion, Rolando knows, with EDCTP, for example, that could actually help to fill this role of building up these ownership taken and initiative taking at the local level. So this is something that we have been working on, and we would like to drive further. Related to that would be the general capacity building, also thinking about that as business schools, we look in the next generation of leaders. So we actually develop with our MBA students, with our executive education programs of younger health professionals or health sector executives, that we can give them or train them with the skills they need in order really to embrace digital transformation, not only to know about it, but really to embrace it. And which I always insist very much also to learn about a lot. That's Jima, but like really to listen to you, because sometimes because there are a lot of challenges in the low middle income countries, and with the harsh reality of African countries, there are some very genius and very interesting solutions that are being found. Think about M-Pesa in Kenya. It does not exist in this way in other European countries or American countries. So there's a lot for us to learn. I think here, this collaboration, that was my question also earlier to David, is about how the institutions can actually help to support that. So that would be definitely a role that we have been taking up, and we would like to pursue further. And I think particularly for infectious diseases, this is important. And then it would touch also on issues like the implementation I mentioned earlier, helping that solutions not only are invented, but are really being put out in the real world. Helping startups. In Burkina Faso, I have been supporting for the last 2 years a new telemedicine startup, eSanté, and for the moment they just do they just help patients to take appointments with doctors, no? So they manage the doctor's appointment. But what they tell me, and I think this is really interesting, that just with doing this and offering this to hospitals, they start then to help hospitals say, oh, maybe we can help you how to organize your IT system, organizing your data. So they bring in, as this is the CEO is a computer scientist. They say we actually help them to bring their own, even so it's not the real service that we provide, but in order for our service to work. So there's, I think, a lot of things that could also be done bottom up, and I think business schools can really help here, and it's a role that we like to embrace. And then issues such as looking into all the equity, the ethical and equity issue. That is something that we have been studying. We have been I'm not saying that in Europe we do this better, but I think that there's a lot of a reflection process that we can actually, as partner, we can help to drive and bring in place or put in place the elements or the institutional capacity that is necessary for that. And then another important point would also be this cross-sectoral partnerships, where we can actually help to maybe identify good partners in the private sector that could be helping with this, that would like. I just was at a very interesting meeting at Berlin, organized by the Hasso-Plattner Institute, as you know, the founder of SAP, and spoke with one of the responsible for SAP and he actually said that they're very interested in supporting some of these development, and we as a neutral partner could be the platform of helping this. So just to sum up, one thing I haven't mentioned, we are part of the Business School Alliance of Health Management with some African partners also, so that's something what we can also make use of, also put out their studies and ideas and help driving the capacity development and the development of local digital health ecosystems. So I would close here. I'm happy to listen more, and I would love to find some ways together, or in one way or the other, to collaborate. Thank you very much.
Wonderful. Thank you so much, Magda. Nima has a question. I see your hand up, Nima. Go ahead.
Thank you so much, Maya. Thank you, Magda, for that present. I mean, it was amazing. I was like on my seat, like, oh, I have something to add, I have something to say. And I think it would be great to have a lot of follow-up conversations. But first, I'll start off, if you allow me to say one little phrase in French. I love when you talk about the ingenuity, you know, that is, and we say in Congo, rien n'est impossible pour le Congolais. Nothing's impossible for Congolese. It's really amazing to see them, regardless of any challenge or barrier, just this level of solution-driven thought and like, let's find a way to come around this. And with that, I was really, really touched about what you were talking about, domestic resource mobilization. As a result of, you know, what this have happened, that is exactly where these countries are at. That is exactly where the DRC is at. Let's now think really seriously about what do we need to do and how do we especially engage the private sector. And if you take a look at the context of the DRC with the immense mining activity and mining sector and others that are there, and we are currently working with government stakeholders in beginning real deep reflections on that level. And I think it would be really lovely to get more insights from you and from that aspect in terms of how do we engage those with that business intelligence to come on board to think about concretely, how can we pull resources? Because what we find, which is unfortunate, for example, you have a very robust CSR programs with a number of these mines, and they're doing great things. But we go and we have seen these resources are wasted because there's not that linkage with the health experts behind to say, this is the way we should do this, that, and the third. But anyway, I will end there. I could talk on for days about that.
Yeah, no, thanks thank you for reminding me of that. Like, we have those people in our classrooms, and those people that come to us and said, we want to make a meaningful impact. And if we can link these to the need on one side and their wish to really make something meaningful, it's something that is assured to be meaningful, that there is, like, we would be like a neutral partner of making that link and help that really impact will come out of it. So happy to have more reflection on that. Thanks a lot.
Thank you.
Thank you both. This is really interesting, and I love seeing two great minds come together. So always a win. Abdul Hamid, I'm going to open the floor to you. I'd love to have you introduce yourself briefly, and really excited to hear your talk today.
Yeah, thank you very much. My name is Abdul Hamid Yahya. Currently, I'm the Deputy Director for eHealth Africa. That's for Global Health Informatics. What that simply means is I'm charged with the responsibility for leading the organization collaboratively to design and deploy digital solutions that will help to accelerate the achievement of our programmatic objectives. And our programmatic objectives are quite simple: strengthen health systems, respond to public health emergencies, especially in vulnerable and underserved communities. So that's basically what we do. So in line with what we do and the broad topic today, or the theme of discussion today, which is a little bit broad, I decided to focus on a specific area, which is the sustainable implementation of digital health solutions in resource-constrained environments or communities, because that's kind of aligned with what we do almost on a day-to-day basis. And I've been involved with that for almost a decade now. So I thought I'll speak more naturally to something like that. So I'm not sure if I can dive straight in. I have some slides. Can I do so?
Absolutely. The floor is all yours.
Okay. Super. Thanks. So I think I need to share my slide from here. Okay, give me a couple of seconds. Yeah, I need some confirmation if the slides.
Okay.
Yeah.
Yeah.
Okay. Great.
You can see.
So, okay, super. Let me push this to the side a little bit. 1 second. Yeah, I think the Google Meet is not too happy that I'm trying to push it aside. Sorry about that. Yeah, so I think I got it eventually. So sustainable implementation of digital health solutions in resource-constrained communities, building resilience amid global challenges. I guess this kind of aligns because Nigeria, I'm going to focus on Nigeria, but Nigeria is also a part of LMIC, which works well with the context of the discussion. Yes, so outline of my conversation will be to still give some little theoretical background, just to provide the framework for to guide the discussion. But the real business deal, the real deal will be the last couple of slides where we talk about our own case study, our experiences of building sustainable digital solutions amid a lot of challenges. But I just thought it's still good to provide some background. This is kind of a snapshot or landscaping or providing background or context for what currently is achievable in resource-constrained environments in Nigeria. You have, we are most impacted, such areas are most impacted by global challenges, climate change, the pandemics, COVID-19 and other similar pandemics. We've also worked on Ebola crisis as well. So we kind of trying to paint the picture of what it looks like. So digital health solutions can provide or help in building resilient solutions for some of these areas. But then there's a big question: can we even deploy digital solutions sustainably? So that's part of the question that we will answer. We have a case study where we've done that successfully over the years. So some of the challenges in to put it into context, some of the challenges you have in resource-constrained communities, inadequate infrastructure, you have limited power supply, you have a limited internet connectivity, low mobile phone usage, there could be poor application design challenges, then there is lack of technological competence, then shortage of even healthcare professionals as well. Sometimes you even have weak policy and regulatory frameworks, and then the fact that you have frequent change in government or leadership, it doesn't also help either, right? So these are some of the issues that we have. But in spite of these challenges, the digital health positively can help to scale solutions and so on. So in Nigeria, part of the effort that we applaud is it's what we call the 3MTT. That's getting 3 million tech professionals. I think it's by 2030, if I'm not mistaken. So that's a huge drive where we intend to export talents. Even after we have talents that will be sufficient for the country, we want to export to other countries. I just thought that has always been a very good initiative that we like to always point out. Regulatory frameworks are there to help. We have the Nigerian National Health Act. We have the NDPA, Nigerian Data Protection Act, and then also we have the Africa CDC transformation, digital transformation strategy. So some of the strategic pillars quickly now, about I think 5 of them are key that I would like to touch on briefly, depending on how much time permits: policy, governance, infrastructure and technology, collaboration, capacity building and human-centered design. All of these are very key in frameworks that you can use to build sustainable and resilient digital health solutions. For policy, we need to be able to regularly develop policies, update them, and make sure we enforce them. I think in some of these communities in LMIC, it's not about the policies, it's about the enforcement that is weak, in our own opinion. Then you need to make sure you encourage local and other stakeholders, carry them along even when you are building the policy, so that you don't just create a policy and then you dump it on people that are going to be key stakeholders, right? And then you also ensure you align policies with the practicalities on ground. And then for infrastructure, which is to me the most interesting bit, you need to make sure you invest in scalable infrastructure. The DPI, DPG approaches are cool. Then when you're building solutions, make sure they are offline first, because we're talking about resource-constrained environments. Adopt low-tech technology. Sometimes the full-blown application might not be feasible. You need to have other versions, light versions, where you can use SMS, USSD modes that people can have more access to. We prioritize open source platforms because they are going to be the key to sustainability, right? Then you also make sure you align with community needs, integrate emerging technologies, and so on. Then we have collaboration and partnership. This is also key. For capacity building, we need to make sure we train. We need to also make sure we align with the community. That's where it's key. you need to offer incentives at times. That might sound ridiculous, but you're training people, but you still need to offer them incentives. And sometimes also you also need to make sure that you take the cultural perspective of the community into, put it into perspective, because it will be quite key. Human-centered approach or human-centered design. I was happy when I heard that mentioned earlier in the call. You need to make sure you understand the root of the matter, so that you don't end up addressing symptoms. We've seen a lot of digital solutions that are addressing symptoms instead of the root cause. Then you get that through collaborative design and co-creation. Make sure you work with the team, the communities on ground, all grassroots stakeholders, so that you can, through them, you can get to the root of the problem. A user experience, ease of use, inclusive designs. Make sure you don't exclude the digitally challenged or digitally disadvantaged or physically challenged. All of this, you have to make sure you include them into the digital solution. If not, you might end up increasing the gap rather than closing the digital divide. Cultural sensitivity, that is key. Prototyping and piloting. Don't jump into rolling out a solution or deployment. Make sure you can test low fidelity prototypes, high fidelity prototypes, piloting and all of that before you get into the full solution. That has been very important. And now to the business end of the conversation, like I mentioned, this is where we tie all of the pieces together. The frameworks for sustainability and resilience, and then the experience we've had on the field, impact. This is slide, it kind of touches on everything. So we have a lot of use cases, but I'm always interested in this one because it's often been neglected. People look at medical records, EMRs, EHRs. I think that has also been mentioned during the call, but we often forget about the logistics or supply chain side, which is also critical for healthcare commodities. So the healthcare logistics supply chain in Nigeria has a lot of issues, from being paper-based initially to even where you have some of the infrastructure or tech, it's not really working as seamlessly as it's supposed to be. So this was what made us to come into this space. That was in 2014, 2015. Yeah, 2014 exactly. So we created LOMIS, which is a logistics management information system. We created it to help address some of these issues. So how did we approach it? We've talked about framework for sustainability and resilience. How did we apply that? So we made sure we took a human-centered design approach, so that we found the root cause through collaboration with grassroots stakeholders to understand what the real problem was. And then it was an inclusive design to take care of the physically challenged, the digitally disadvantaged, and also so that made us include accessibility and low-tech approach that I mentioned earlier, so that people can have access irrespective of whether they have expensive smartphones or not. Then capacity building programs to ensure that the work skill gap is increased. And then we also made sure that it's an offline first capable system, so that when you have those internet issues, the system can still work and sync where internet connectivity is available. Of course, cross-sector collaborations, government, community, grassroots, CSOs, technology, and donors, we all put all of these fused together in order to make the deployment of LOMIS a success. Stock management was the issue that we found out eventually, because there was no visibility into stock availability at the last mile. And also, even when stock is being delivered, during delivery, during the transportation, there are no visibility on the condition in which that particular stock is being moved. And part of the key stock we're talking about here is vaccine. Vaccines needs to be transported at certain condition, temperature, and so on. So that was key. So if you look at the impact, I'm not sure how well you could see the diagram. I tried to squeeze too many things here because of the time constraint. But then you see the impact. After we implement, we're able to reduce thrive stock out rate from double digits, sometimes in some cases from 80%, 60%, 70% to 4 or 5%. In some cases, we're able to drive it down to zero for a long period of time. That is truly remarkable, especially when you put it into perspective that stock outs could mean the loss of life, because when you need a vaccine and you don't know that you don't have it, a child that is supposed to have that vaccine goes unvaccinated, and all of the ripple and domino effects that it can create. So stock outs, it's very key to keep stockouts at the barest minimum, and that's what LOMIS has helped us achieve across all of these states in northern Nigeria that we've implemented LOMIS. Some of the data is there. Because of time, I think I wouldn't go into that. Then fusing, trying to underline, I think this will be my last slide. The other slides, I will just mention them. I don't have to go through. Fusing all of these key points together, the frameworks we talked about for resilience and sustainability. We know what the problem is, but then how did we do that? How did we build resilience? During COVID-19, during the pandemic, when most other solutions were struggling because they were not built for the pandemic, Lomis was very active. It played a crucial role in maintaining the supply of vaccines and essential medicines. And during that period or thereabout, we had about 17 million vaccines that were transported and that Lomis helped to create or provide visibility into. And this ensured continuous accountability, transparency in vaccine distribution, even amidst the global supply chain disruption. So we thought this is a good experience to share, to demonstrate our resilience, even when there are global crises or global challenges. Then the system's offline capability and SMS integration and USSD make it particularly well suited for regions with resource constrained regions, like where we mostly work, where the vulnerable and the underserved communities or populations are. Then intentionally designing for sustainability, that's also key. We use robust open source systems to avoid the need for expensive recording licenses. We've seen where that is a problem for governments to maintain expensive proprietary licenses. Once the donor or the partner or the implementing partner has finished his contract, you find out that those solutions might get dumped because continuity becomes very difficult. So we always make sure we do that. Then the human-centered approach, the only thing I will point out here is, apart from engaging the people to get the root cause, make sure you design for concurrency. The system should be scalable, the system should be robust. We had to be called in to strengthen so many existing digital health solutions during the COVID-19 because they were working superbly well. But when the COVID came and there was a lot of traffic, increased usage, the systems could not handle it. So when you are designing for underserved areas or vulnerable populations or resource constrained areas, make sure you build systems that will scale, build systems that can handle a lot of concurrency and so on. Transitioning to the government is also key for sustainability. Make sure you carry them along. You have defined dates. Those dates will change if you're working with the government. It could change by years. In some cases, it could change by 3-4 years, but at least you have a plan. And even if it takes 3-4 years to hand over to the government, 3-4 years extra, I think it's still worthwhile than just deploying solutions that don't have a timeline when you're going to transition to the government. It makes the government take the solution seriously. They have an ownership stake. So all of those things factor into the sustainability as well. Then capacity building is key. You need to make sure you train the people accordingly. In terms of in line with the realities on ground, we've seen where people come in and they want to deploy electronic training on Udemy or it doesn't work in many cases because these are people that are struggling to spend time digitally on devices. So it's very hard. You have to understand the peculiar area. If you need to incentivize, you do all of that. Then I think lastly, what I'll talk about will be the feedback, iterative feedback, which is part of human-centered design. Because if you're working with the community, the grassroots, the people, the key people at the grassroots or community level, you are able to identify the problems early enough, and you are able to keep refining the product to suit the peculiar needs that arise. It's in line with this now that we are now having to revamp the Lomis solution with AI integration. And I'm glad to mention that we had support from WFP, the World Food Program, and we're also currently working with Tech to the Rescue organization as well to integrate, put AI integration into the Lomis platform so that we can have prediction and we can have automated triggered deliveries, which will seriously help with this. So that's part of what we said, iterative feedback, so you can continue to use emerging technologies to enrich, further develop the software, upgrade the software applications or solutions to serve the community even better. So what I have here, not really worth mentioning, but we just thought it's good to say that as we're doing this in Nigeria, there are other people, communities where it's happening in other part of Africa. MTBA is a particularly an interesting case for us in Kenya. And then we also have zipline drone delivery, which is happening, I think, in Rwanda, Ghana, and even parts of Nigeria as well, just to highlight how they have also been using either emerging technologies or trying to build resiliently or sustainably sustainable digital health solutions. I think that's all. I just have a quote, end with a quote. As we build, let's build for One Health and the planet as well. So build for the human, animal, and everything, and then build for the planet as well. So that's all.
Thank you so much, Abdulhamid. And really interesting about the drones is a subject that I've been interested in a while to incorporate snakebite antivenom into. So always kind of been interesting to see how that's building up in particular geographies. I think it has a lot of potential to expand for a lot of different use cases. So really great. And like you said, the logistics really needs to be, we can't do anything unless we figure out our logistical system. So if medicine isn't getting there, you know, no matter how strong we make our EMRs and HMIS, we can't do much. So Nima, I see your hand is up.
Yeah, thank you so much, Maya. Thank you, Abdulhamid, for that amazing presentation. It was really lovely to hear all of the different similarities between the realities, like in Nigeria and in the Democratic Republic of the Congo, when you cited some of the challenges in terms of infrastructure, internet connectivity, etc. And I wanted to ask you a question. You know, how do you address that challenge, you know, about internet connectivity? Because I don't know about you, but a lot of times when we talk about digital and digital solutions, the first thing that people will bring up is say, oh, but the Congo has such an issue with connectivity and things of that nature. And what are maybe some of the ways in which you respond to that, or ways in which you've been able to get around that challenge existing in Nigeria? Thank you.
Yeah, thanks, Nima. That's a very key question or observation, I should say. Yeah, it's similar. Part of what we have always done is the offline first approach, where you make sure that where the internet is epileptic, you could still have services, because you could have services for 3, 4, 5 days, natively built on the system, on the platform that they're using. Then when they move to where there's internet connectivity, there is some sort of sync, and then the data gets synced and then updated again, and then they start all over again. So that also helps. And then secondly, it's also to get a light version that we've done in some cases. The robust application might not work where internet is extremely poor or even unavailable totally. So you now have a USSD SMS-based light version of the application. The downside, of course, is you might not be able to have all of the feature on the main application. You won't be able to have all of that, but at least you still get some basic services to the community. And I'll tell you something that is even funny. Sometimes when the internet is available, very limited, you still have people using it for different non-productive purpose. So we found ourselves in that situation. You provide the data free of charge for people to use it for the work, and then you find out that people are using it for a different situation as well. So what we've done with that is we work with telcos, we lock the data down, we lock the bandwidth down. So if it is 2 gig, we give you 1 gig free. You still do your browsing or whatever, but we lock 1 gig absolutely for our work, because that is critical. So that's also something that has been very helpful with the telcos. Yeah, thanks, Nima, for bringing that up.
Thanks, Abdulhamid. Thank you.
Great. Well, for those of us still on the line, I have a couple questions for the whole panel. First of all, and feel free to jump in and raise your hand, or just speak up with your thoughts on how can we ensure that digital health innovations are designed and implemented in ways that truly serve marginalized and underserved populations beyond the pilot phase. Magda?
Well, basically, we work a lot with needs-based innovation. No, this is Stanford Biodesign that started with that, and we have, and you, Abdulhamid, you talked about human-centered design. It's a really going there and asking them, and it's a great way of really adapting it to the real needs that they have, whatever the technology is. But the second more important point is to get this ownership, the local ownership, that they say, this is we have helped develop it, this is ours, and we will use this now. And I think that's an important part. I'm just teaching human resource management in a health master in Rome. I just come back from that yesterday. I have another few days next week and the week after. And I use a case study of integrated care by the Basque Country here in Spain. They have done a very great implementation with Rafa Bengoa, who also was at WHO for the non-communicable diseases. Anyway, long story, but the short note is what he insisted on saying, We have things that we need to do top down, like he said, salaries of doctors. Probably you wanna do like a national campaign. You want to do top down, but to be really successful in really implementing it and having the take up, you need to combine the top down with bottom up elements. And I think that's the important message of really bringing people in. And maybe there's a little difference on how it's done in one city in Nigeria, like in Ibadan or in Lagos. Oh, you have a big country, the Congo is a big country, maybe slightly different, but you actually hope that it is developed in the right way. So we don't look for having it all the same for everyone, but having it applied, but getting the same quality of data, and comparable data and interoperability. These are the top-down things that we need to impose. But I think to have good bottom-up elements and then ideas of transferability, Abdulhamid, you mentioned also sustainability and scaling, etc. These are all elements to think about right from the beginning. How then I have to go again and then again the bottom up and the co-creation in the next town where I go. It's hard work, but I think it's worthwhile in the long term. Thank you.
Yeah.
Thank you so much, Magda. How do you think we balance innovation, ethics, and governance in digital health, especially when we work across borders with vulnerable populations and during emergencies? Nima?
Yeah, thank you, Maya. I think that's a really, really key question, particularly in the DRC when we have cases of epidemics that have now been seen that they're propagating across the kind of region, For example, Mpox, we saw the most recent outbreak did spread to neighboring countries in the region, for many of whom had been their first case of ever seeing Mpox, right? So when we're talking about strengthening regional networks of epidemic response and things like that, that comes front to mind, because getting countries to agree on the information and data sharing that will be used. So for us, we believe the first and foremost is to be able to identify a certain number of indicators that can be transferable and widely accepted across the region and aligned to. But I think also most importantly, also leaning to what Magda said about having government ownership, but on that regional level, having the regional bodies as well involved in that and taking the ownership, which is why to that question, we've been working particularly with Africa CDC and being able to really continue serving their role as that kind of regional norm setting body and being able to identify a certain level of epidemic indicators that can be shared cross country to allow for that regional response. And I think it's a very important question because we are learning more and more that through COVID and other epidemics, that being able to work or help to respond to epidemics in a vacuum in one country will not work. It has to be a regional way of doing it. I remember when I was in the US during COVID and there was a major challenges in the United States during the COVID, and a lot of that was around that. And the things I kept telling my American friends was like, well, global health doesn't work in an individualistic manner. So, so if you have the state of Georgia, having all these things, but then in Atlanta, everybody want to do what they want and walk around without masks, which was the case. They know, it's on record. But yeah, so I think that would be how I would respond to that. Thank you so much.
Yeah, just wanted to add to what Nima said. I think it's a very critical part of the conversation. And I think continental leadership and policies are required. I'm very happy, was it 2 to 3 years ago, I was at the launch of the Africa CDC Digital Transformation Strategy. I think that's a good starting point. So we need to have such type of policies continentally for AI now, responsible AI use and so on. But beyond that also, I see another drive that is currently going that will be useful. That's the interoperability drive. I'm not sure about other countries, but in Nigeria could be 36 different countries in one, because every state is doing his or her own thing. Every state has her own different policies, and the rest different EMRs. So what has been going on for the past couple of years in Nigeria is harmonizing, integrating the EMRs, providing a standard-based approach, and that's key again. When we design our solutions based on standards, it's easy for those solutions to communicate together, interoperate together, because they are standards based in right from the design. So that's what's happening in Nigeria now. The drive run by NDHI, Nigerian Digital Health Initiative, or something like that, if I get the acronym right, it's driving interoperability across the 36 states. So I see that as a good starting point. If every country, like you did mention, Nima, that in DRC itself, such a huge country, 100 million, if they could sort themselves out into one single interoperable EMR system, Nigeria does the same, then we can now begin to look at how the countries can even interoperate. But it can't happen if within the same country, one single country, you have multiple disparate solutions and digital ecosystems. So I think we are getting there. Not sure who is driving the continental movement, but at least nationally, it's getting, and that's a good sign that I've always been pointing out this past couple of years. Just sorry, I took a lot of time. Just wanted to add that to what Nima said.
Wonderful. And I think I'm conscious of the time. And so I will pass it to Rolando, I think, for some closing remarks. And then if there is any follow-up after that, if we have time. But I want to make sure Rolando has a moment to shine.
Thank you, Maya, and thank you everybody on the road. I knew we would have a great conversation with all these wonderful minds around the screen these days, I should say. But it's fascinating to see the coherence and the convergence of all our ideas and experience. I take note of many of the points that have been said, and I would add some of my comments. As I started saying earlier, the time that we record this, we are at a point in the sector where there are a lot of competing priorities over pressure on diminishing funds, but also global issues that question not only the financials, but the way the sector will proceed, the status quo, the rule of law, and what humanitarian principles are when we approach the needs of the beneficiaries. So when I want to be a positive, and I am a positive person by nature, what I'm encouraged about humanity is that we're still, despite all these challenges, investing in AI and digital health. So the promise of the AI and digital health is really the factor that makes us turn the page and that creates a vector for the future. And over the past few days, I've been participating in several roundtables and speaking about the subject, and you hear and you see, whether it's from the embassies, the developers, the institutions, the governments and the international organizations, that the promise of AI is and digital health, whether it be for emergencies or not, is the opportunity of inclusion. It's the opportunity of targeted resource inclusion and basically engaging everybody. It's a platform and a tool that doesn't know boundaries. There are only technical boundaries, but like diseases and like infectious diseases particularly, can be seamlessly throughout. It is a great platform for dignity. And we often refer to this as privacy, but I refer to it as dignity because it has to do with the person whose face has been recognized while they wait for food in a humanitarian line. It has to do with making sure that your personal health is protected for the future, as you are also used as a resource on a baseline for its research. But also in a positive sense, that it's what gives us the scientific evidence to continue the research that, life-saving as it is, it's been questioned and compromised in many settings. So I'm glad to see that, that at least this is a promise that we're still all invested, intellectually involved, but operationally engaged in a moment where there's also regulation is trying to find the balance between regulation and innovation. And we do need regulation for innovation, but we don't want it to stifle that. So hearing the voices and the comments about human-centered design, about the governance structures that we're focusing, about the adaptability and of these different mechanisms that are being designed and developed, is fantastic to have it as a loop of this conversation that needs to feed regulation and needs to drive the input towards the legislators who are also sitting on the budgets. we're here also to talk about humanitarian emergencies. We're talking about infectious disease. We're talking about pandemics and epidemics. And all of us in one way or another have been involved, whether professionally, personally, or geographically engaged. And I was really encouraged, and it was music to my ears, Abdul Hamid, to hear your work, which, you know, could have been a case study in my PhD on humanitarian logistics. So I've seen to see how amazing it involves is great, because back when, you know, 20 something years ago when I started in this field, it was all about how do we get data? How do we get data that allows us to make evidence-based decisions? And this is exactly what you're talking about. This is exactly how do you make agility and adaptability and alignment of all the different actors in a setting that do not have a commercial driver to work together, be aligned towards a common goal, and data is exactly that. So very interesting to see those cases, which lead me to my final comments, which is, yes, we are investing in this. Yes, there's a lot of progress to be made, and there's a promise for the future, for a better future if we keep going in this direction. But we need new models of working together. We need blended financial models for this. And what I see in your last presentation, but also in the case studies that have been highlighted, are great opportunities for private sector investment, for private sector engagement, for pharmaceuticals. You know, the moment you have this data, the moment you set up this governance and have the inclusion, the dignity I referred to, you are accessing and designing and making the business case for clinical trials, such as the ones that, you know, PATH is rolling out in Africa. We just rolled out an LLM, which is 9,000 entry points, looking at, it's the largest trial in a clinical setting in the continent. You know, many more like this could guide also research and innovation. This data is also, as you very well pointed out in the case, supply chain visibility that allows you to do resource allocation, to do prioritization, to access the most marginalized people that in populations in a difficult setting. But it informs smart procurement, and it helps you to do stockpiling. In Europe, we have been talking about the Critical Medicines Alliance about how much stockpiling should we do of critical medicines. And the sad truth is that if we go by the guidelines of what each country has defined, basically, as one of the pharmaceutical CEOs said, we will be producing to stockpile. Whereas if we are informed in this capacity and we gain that operational agility, we can produce to respond rather than to stockpile to expiry. Which, in closing, brings me back to what we've all saying: capacity building, training, developing leaders. And, you know, Magda, you very well pointed out with, and rightfully so in your capacity, that, you know, the leaders of the future are not just businessmen. They're community leaders, they're community engagers. They're not just scientists who are looking on a lab. They have to be engaged on not only the community, but the politics of it, and the geo sense of where we're operating. They're not just IT colleagues who are designing a tool and coding. They are people who need to be connected to their everyday life. So what I take from this is very much what PATH has as its mandate, which is equity both in terms of response, but in inclusion in terms of design, and a very fearless sense of innovation that, regardless how difficult times can be, there are promising vectors in which I'm very happy to share the day today, in looking at the solution, looking at how we can get through, and looking how we can respond to those who are looking at us for a brighter sense. Thank you so much for everybody. Thank you for your time, and I hope you enjoyed it as much as we do. And I hope the audience, when they get to it, will take as much lessons learned as we have already from the sector.
Thank you so much, Rolando. And I recognize we have 5 minutes, so I'm going to put everyone on the spot for just like one sentence. If donors and people who are really wanting to help in this field and help in these areas are watching this video, what is 1 or 2 sentences from each of you on where we need to see the investment? What are our priorities and our next steps? I'll start with you, Nima.
All right, let me get my improvisation thing. Oh man, okay, to the donors to thing, I would say my sentence to them would be, come together in a collaborative way to find solutions that are homegrown, that are driven in equity, and that are really driving domestic resource mobilization. Because together we can move mountains and make ripple tides through any type of challenges that we may be confronting globally as one people. Thank you.
Thanks, Nima. Magda?
Yeah, thanks. I think building on what Rolanda said, thanks. This was really speaking out of my heart. I think we should formulate this in terms of recommendation to potential funders. I'm thinking about the European Union, for example, with their research projects. They always ask for impact, like we described impact. And I think that all should have an element of capacity building, an element of sustainability, an element of business concept development that actually goes beyond, actually not stockpiling, as you said, Rolando, no, but really goes beyond and said, how will this work in real? So that would be one point. Then another would be the funders could be bilateral funding, the trust funds, etc. More capacity building, more support for capacity building. I don't think that there is enough funds out there. And related to that, WHO and other organizations involve the local business schools. They love to make they have the knowledge, they have the skills, they can train very well, and they have the network. So there's a lot that they can contribute. And I think the future programs should at least have an element. And we're happy to help this with part of our business school network that we have, or this, and trying to make this happen. I think that will also then bring sustainability in the implementation. Thank you.
Thank you, Magda. Abdulhamid?
Yeah, I think in a sentence it's difficult. I'll try as much as possible.
Sorry.
Yes, I know. But what I would love to see is streamlined efforts to deploy community-driven digital solutions to sustainably solve health problems. And I'm key about the streamlined. There is a lot of parallel efforts ongoing. We are talking about resources being scarce, but you find out that there are duplication, the same thing being done by different donors. So if we can streamline, if the donors can come together and streamline the effort, these resources might actually be enough rather than duplicate. If you can concentrate and make sure it's streamlined, then you know how to beat this challenge that we have of resource constraint. I think that will be very key.
Amazing. Rolando, any final thoughts on your end?
I think enough of it has been said. Now it's for us to keep working together. This is just the beginning of this forum, but I invite all the other people watching this in the future to reach out to us, to reach out to each one of us individually or collectively, because this is just the beginning of the conversation. We're starting the Global Health Forum here in Brussels this week. There's WHA happening next week, but also this is a year of a lot of structural changes for our sectors where we should be not only engaged, but exchanging as much as possible. Thank you very much.
Thank you. And I really want to give a really big round of applause for the Infectious Disease Alliance for coordinating and arranging this. They've been working so hard and moving so fast and doing such an amazing job in this space. So really hats off for all your amazing work and for coordinating and organizing a lot of these amazing events. There are a lot of events coming up. So as we move forward, please keep your eye out for events during the WHA week and beyond. There's a lot of exciting discussions happening, and we're really excited to work with Infectious Disease Alliance.